Good afternoon. My name is Dr. Dan Simon. I'm the Chief Clinical and Scientific Officer of University Hospitals. I'm joined here today with Dr. Joe Sabik, our Surgeon-in-Chief, and Dr. Willie Brien, our Chief Quality and Medical Officer of University Hospitals. We're here to update you on a very important update related to elective or non-essential surgery in our health system. Governor DeWine and the Ohio Department of Health have just issued a guidance related to non-essential surgery. This has an enormous impact on the hospital and the patients in our community. It's very, very important to emphasize that our overriding principle is to preserve the doctor-patient relationship and the ability for us on a case-by-case basis to offer personalized, compassionate, and safe care to our patients. That is our overriding goal at this time. What I'd like to do now is turn to Willie Brien, who's played an important role on the Governor's Advisory Committee developing this guidance. Willie.
Thank you, Dr. Simon. First, let me thank all of you, part of the UH team, for the incredible work that you have done and continue to do every day on behalf of our patients at University Hospital. Please be sure that our UH leadership team will continue to update you on the changes of this very fluid healthcare environment. During the unprecedented emergency, our focus, as Dr. Simon says, will remain on providing the resources needed to our employees and healthcare providers so that you can deliver the highest quality of care to all of our UH patients in the safest environment possible. To that end, today the governor came out with some very clear guidelines. He warned us that we needed to brace for the impacts that both the state and the nation are facing with regards to personal protective equipment. I want to share with you that it is expected that the amount of PPE that Ohio will need to deal with this crisis is equal to the amount of PPE available nationally. The governor recently obtained from the national stockpile PPE that was amounted to about 3% of what he believes Ohio will need through the course of this emergency. Recently, the U.S. Surgeon General, the American College of Surgeons, and numerous other public health experts have recommended suspension of all elective or non-essential surgeries. And Governor DeWine issued his proclamation today around specifically that, and this will go into effect at the close of business on March 18th, which is Wednesday. So why are we looking at this, and why are we being asked to cancel this non-essential surgery and procedures in our system? The governor's order is specifically intended to protect patients and providers. It's intended to preserve critically short supplies of PPE and preserve inpatient bed capacity and other equipment that we know are needed for the critically ill patients, particularly HEPA filters, negative pressure rooms, and ventilators. There's been a criteria that should be used throughout Ohio, and this will affect all hospitals in Ohio, determining what procedures are elective and which ones need to be postponed or suspended. The criteria for cancellation of non-essential surgeries and procedures that utilize PPE are based on the following criteria. If none of the following criteria are met, the surgical procedures will be postponed or suspended. These include threat to patient's life if surgery is not performed, threat of permanent dysfunction of an extremity or an organ system, the risk of metastases or progression of staging in cancer cases, and the risk of rapidly worsening to severe symptoms over time. As a result of this, we at UH have been working over the last 24 hours and longer to come up with a governance structure for each hospital and each outpatient surgery or procedural provider in the UH system. And this has been established with an internal governance structure that's being led by Dr. Joe Sabik, and I'm going to turn it over to Dr. Sabik to share that with you.
Thanks, Willie. Well, good afternoon, everyone, and thank you for your attention to this very important matter. What I thought I would talk about in the next few minutes is, first of all, the governance structure that we would like to put in place for both here at CMC and for our community hospitals. But also I can imagine this is creating a lot of anxiety for all of you with your individual practices because we don't have much time to enact what the governor has ordered us to do. So I'm going to spend a little bit of time about how we're going to handle the rest of this week and then talk about Monday moving forward. First of all, in terms of our governance structure and what we need to do, I think there are two caveats here that are very important. We don't want to be obstructive, and we also know that the practice of surgery might be a little bit different at CMC and at our community hospitals in terms of leadership structure. So we've developed a governance plan for CMC and another governance plan for our community hospitals. We want to make this as simple as possible for you. And so we've kind of modeled it after how we every day we attest that there's been no change in our patient's condition prior to them having surgery. So that update to the H&P that we do the morning of surgery. So we believe the best thing to do is to have the operating surgeon attest that the patient is needing one of the operations for the 4 reasons that Dr. Brien just mentioned. And I thought I might mention them as well because they're incredibly important, because what they do is they define what is considered essential surgery. Again, is there a threat to the patient's life if we don't perform surgery? Is there a threat to permanent dysfunction of an extremity or organ system? Is there a risk of metastases or progression of staging? And is there a risk of rapidly worsening to severe symptoms? This attestation form will also need to be signed and approved by either the department chairperson or the CMO at CMC. We do understand there might be situations where people may not agree, and so we're going to volunteer, Willie and myself, here at CMC to adjudicate these type of problems. One thing I do want to emphasize is we do not believe that this attestation should apply to patients undergoing emergency surgery or those patients already admitted to our hospital because they are obviously undergoing essential care already. Now, how about the governance structure at our community hospitals? Once again, we believe it's important that this operating surgeon attests that this patient meets one of those 4 criteria that makes it an essential operation. This form must again be approved by either the chair of surgery at that hospital or the CMO. And once again, if it does need to be adjudicated because there's a difference of opinion, Dr. Brien, as our system CMO, or the institute chair will adjudicate that. And once again, we don't expect this to apply to emergency patients or patients who are already admitted in the hospital. Now, we don't have much time to enact this, as you've heard. This goes into effect at the close of business day on Wednesday. And so for our patients undergoing surgery on Thursday and Friday, we have a few things to do. Number one, we need to be able to identify those patients who are undergoing non-essential surgery. So at CMC, our expectation is that all of us will look at our operative schedules, and by tomorrow morning at 8 a.m., notify the OR scheduling office, as well as Amy Boone and Dan Tawarnicki, that your case will not be essential and therefore will need to be postponed. As you know, here on main campus, we do have pre-op nurses that call the patients the day before surgery. Those nurses will call the patient and let them know that their operation is being postponed, due to the order that we are not allowed to do essential surgery. However, we will also tell them that the surgeon's office will be reaching out to them very shortly to talk to them about how we will reschedule them in the future. For cases that are scheduled beyond March 23rd, it will be the responsibility of the surgeon's office to let the patient know that their surgery will be postponed and rescheduled. Also, for cases that are scheduled after March 19th, our expectation is that the attestation form will accompany the scheduling request, and that the attestation form will be completed by the surgeon and signed by the respective department chair or CMO. A little bit different for our community hospitals, just understanding that we might not have the same infrastructure. But once again, we would like the surgeon to let the operating scheduling office at that hospital know by 8 a.m. tomorrow morning. How the patient will be contacted will depend on the services that are available at that respective hospital. If the hospital has nurses that can call the patients the day before, we ask that that is done. But if not, we ask that the surgeon's office reach out to their patients and explain to them. We're going to follow the same guidance that we had at main campus, that beyond March 23rd, it will be the responsibility of the surgeon's office to reach out to the patient and to tell them that their surgery has to be postponed, but will be rescheduled in the future, and that once again, for any cases that are scheduled after March 19th, that case scheduling request is accompanied by a signed and completed attestation form. Thank you very much.
Well, thank you, Willie and Joe, for that great review. We want to move to questions quickly. However, I want to emphasize again for our viewers, we are putting this and the patient at the center. Our goal is to evaluate every individual patient on a case-by-case basis, preserving the very important relationship between the doctor and his or her patient. This is important because each case is individual. We offer personalized and compassionate medicine. These same rules will apply not only to surgeries, but also to interventional procedures. I'm very pleased to report that Joe Sabik, Dan Tornicki, and many others have compiled extensive lists based on the input of department chairs and institute directors that will be made available so we can understand quickly what we believe on a high level is essential or non-essential, and we will distribute those this afternoon. At this time, I think it would be great to take some questions from the viewers, and we'll bounce them off both Willie and Joe.
Dr. Stanky, we've been monitoring these emailed questions from physicians here off camera, and we're prepared to share some with you now. We'll begin with this question: how long do you anticipate this delay will last, as we consider that when we are making future appointments and when we are delaying these appointments?
Well, it is very difficult for us to anticipate how long this is going to last. There are estimates based on epidemiology of this virus and pandemic that this could last 60 to 90 days. We do not recommend rescheduling patients at any defined time point right now. We think the situation needs to be monitored. We will be collecting a very comprehensive list of all surgeries and procedures, and we will monitor the situation of the pandemic and then follow up with patients when they can be appropriately scheduled.
So you mentioned already that a large part of this is in preserving the equipment that we have. Could you give us some specifics about what that equipment is, and can you give us some advice about how we can preserve that during the procedures that we're going to be doing?
Joe?
Sure, that's a terrific question. You know, when we think about personal protective equipment, you know, just picture someone in an operating room, their mask, their hat, their gown. You know, these are very limited supplies. So it's very important that we do whatever we can to conserve this vital equipment. One of the things, you know, that sometimes happens in our attempts to be efficient is we open too much supplies. It goes to waste. We cannot waste any of these supplies. Really, I would say that we should really only open things on demand. We don't want to open extra gowns. We don't want to open extra gloves. I ask people to be careful when they're taking their masks and their caps out, that they don't drop other ones on the floor and waste them. You know, we all have to be good stewards of our supplies so that we can, you know, take care of the patients and make sure that all of us have protection in the future when we do need to take care of our critically ill patients.
Willie, do you want to talk just a little bit about answering that question with respect to using appropriate PPE on the floors and out of procedural and surgical areas so we do preserve it for where we need it?
Sure. So one of the things that we have done very well, and we do this and update regularly because the guidelines continue to change from the CDC and the World Health Organization, is what those guidelines are for the use of PPE when we're caring for our patients. And on the floors, you've already heard around the PPE around gowns, gloves, face shields, and masks, surgical masks, and then the N95 respirators. On the DWP, we have a very specific set of guidelines of when these need to be used, and when they're not on that list, they should not be used in order, again, to preserve the PPE. Without going into the details, because it's a very complex board, it basically, we want to minimize the number of people that go in and out of rooms that require the use of PPE. We want to minimize, even in the operating rooms, those people who may not be essential to the actual surgical procedure, and reduce the number of people that are moving into a room, taking their equipment off as they leave to come, and then come back and start a procedure. So we're really going to be working on timing of this as well, so we can preserve as much of the PPE as possible. This is really important because as the number of cases ramp up, the need for using PPE for these either COVID-19 positive patients or those patients under investigation is going to increase. And we want to make sure, again, that we have adequate supplies of the PPE for our key employees who are taking care of these patients, and our providers who are working with these patients every single day. To that end, we have other plans in play that could occur or could be triggered in the event that we have a widespread outbreak of hospitalized patients, where we may have to cohort patients either within a given facility in a certain area to preserve PPE and have healthcare providers work in that area, or potentially working at hospitals where they may become sites for patients who are COVID positive or persons under investigation while we're screening. So again, we preserve as much PPE as possible.
So beyond the procedures and the surgeries, are we clear to continue elective office visits?
Willie, you want to take that question first, and then?
Sure. So the key thing that we're trying to do here is continue to provide the appropriate care for our patients. And that's the key. And while office visits are often elective in nature because the patient is not in the hospital and can choose to come in, many of them still need to be seen on a regular basis, either for follow-up or with new disorders that they really need to have treated. And we will continue to provide that care. And the expectation is our providers will continue to be open for business. Having said that, we are continuing to come up with additional changes to that, so that where we can avoid those appointments, such as annual checkups, and as an orthopedic surgeon, if somebody needed their checkup for their 1-year anniversary for their hip replacement or knee replacement, that can certainly be deferred, and we would suggest that that be deferred to a later date. However, for those patients that have acute illnesses or have chronic diseases that need to be managed, we will continue to be open for business. We're also going to be expanding our telehealth opportunities so that patients who don't want to come in or maybe have those chronic diseases that can be better treated through telehealth to avoid any potential exposure to other patients that may be sick, we will offer that through our telemedicine program that is now expanded. And lastly, we will be coming up with some other guidelines around new well baby checks and pediatric evaluations that we're working with Patty DePompe and Dr. Marlene Miller right now on some new guidelines around how we're going to deal with those patients as well that may need to be seen, but may not need to be seen in person, or may be able to be seen in a cohorted area where there are not respiratory patients also coming in.
I think, Willie, you've raised a really important point. As a cardiologist, I'm thinking about the management of heart failure patients. They're at high risk for complications of COVID. Our intensity in the primary care, in the primary cardiology setting, needs to be intensified to keep them out of the hospital. The contact with heart failure patients, patients perhaps with COPD, needs to be more intense, so that via telehealth, via even telephone calls, our interactions with patients go up. It's that dose, so to speak, of Peter Pronovost telling us the dose of primary care here is important. We want to keep them out of the hospital. So more important than ever to provide these services to patients, whether it's whether it's via telephone call or in-person visits.
So with one of the main purposes being to preserve the use of PPE, what about surgeries like endoscopic sinus surgery, where gloves only are needed? Do those have to be canceled as well?
Joe, do you want to take that question as a surgeon?
Yeah, I mean, if you read the ruling very carefully, it really addresses things that require PPE. And so you could argue that it doesn't require PPE, but I think I will point out this is going to be a fluid situation. You know, we don't know what the demands are going to be on our health system in a week or 2 weeks or 3 weeks from now. Right now, obviously, we have the capacity to do whatever we need to do. But I think that, you know, being good stewards of everything that we have in the health system, I think we're all going to have to use individual judgment as to what's the right thing to do.
You know, our chairs and service line directors and leaders have worked very hard to provide, I think, a good listing of what procedures are essential and non-essential. I know that Dr. Nicole Maronian, our chairperson of ENT and head and neck surgery, has that specific surgery on her list, and we will refer this individual to Dr. Maronian if there are any questions. And we will distribute that list of essential and non-essential as a rough guide for what we think is where the surgeon should start in this evaluation.
You know, I think, first of all, I completely agree with you, and I think one of the nice things that the governor came out with is they don't want to disrupt the patient-physician relationship. And although we spent a lot of time coming up with procedures and guidelines, there's nothing that's better than understanding that patient and understanding that relationship and what that patient needs and how it fits into what we need to do. And so there is going to be flexibility, but again, I think we should all be very good stewards of the health system.
So it's becoming very clear now how University Hospitals is going to handle this moving forward, but how do we know that other hospital systems will do the same?
Well, Willie, I think that's a good question for you because that gets to the governance and the ability of the state to monitor what we're doing.
So there is a governance process. The governor's decree is very, very specific, and that governance process is being established right now, and the monitoring and oversight will be done through the Ohio Department of Health. Dr. Acton, who is the head of that, has done a remarkable job in sharing information and being an active participant and working with us and other health systems across the state to come up with these plans and eventually the monitoring plans that they will use. But make no mistake, the governor, who's been a national leader on this issue and many others, has made it very clear that there will be oversight, there will be management, and this is an expectation that will be carried out across the state for every hospital system in the state.
You know, I would also mention, and I think it's really important for our university hospital community to know that we have been reaching out and collaborating with the Cleveland Clinic, with Metro, and St. Vincent's. This has been, I think, very inspiring for us to see Tom Zenti and Cliff McGarrian and Willie and me working with our counterparts, Tommy Mihailovich, Bob Wiley, and Jim Merlino. We've drafted things together to really preserve the importance of this doctor-patient relationship that needs to be personalized to the patient. We're working together on drive-through COVID testing. Just this afternoon, Jim Merlino and others reached out to us to say, can we see what you're determining to be essential and non-essential surgery? We want to be on the same page. We're together. And I think this is the time for health systems to come together, and we are doing that.
Speaking of governance, I'd like to get back to one other question about Rainbow specifically. Do you anticipate anything being different there?
Well, yes. As Patty DePompe and Marley Miller and Ed Barksdale have always taught me, Rainbow's a very special place, and there are different things that have to happen there. We have been in very close contact with Patty, with Dr. Miller and Dr. Barksdale. Their assessment of essential and non-essential may be different than adult specialties, although I have to mention that Dr. Barksdale and his colleagues have had input into determining their own issues of essential and non-essential. We're working closely with them. There is no question that this has to be tailored not only to Rainbow, but Dr. Ted Technos, our president of Simon Cancer Center, has developed very specific guidelines related to cancer, which is very important. The guidelines have gone out of the way from the governor to mention that cancer is very special. We don't want to delay cancer services to allow for metastasis. We don't want to delay cancer services to cause upstaging, going from a curable stage 1 to possibly an incurable stage 2 to 4 cancer. So cancer is special. Ted is addressing that. Rainbow Babies and Children is special. Patty DePompe, Dr. Miller, Dr. Barksdale working very hard for that as well.
What advice do you have for some departments that are essentially now looking at hardly any procedures for the foreseeable future in terms of staffing and otherwise?
Well, I think maybe we could take this question together. This is a tough one because I think we do acknowledge that some specialties have more non-essential surgery than others. Neurosurgery, heart surgery, pretty much essential most of the time. Other specialties, possibly not. We're going to be working with chairs, institute directors, and service line leaders to assess the impact of these new guidelines, which are only about 2 hours old right now. And we're going to evaluate that on the volume. We're doing those estimates right now and forecasting, and we are going to be working with those departments. I think before we came on live, Joe and Willie talked about the fact that we have shortages of people in other areas. And one of the things that we can talk about, perhaps Willie, about either training or moving people to areas that we need help during this very emergency time.
Yeah, so I think that that's a great point, Dan. And we are taking a look at that. Right now, we're in good shape, but again, we are in the exponential phase of this epidemic in Ohio, and we're behind some other states that are have started a bit earlier. California hospitals, Washington State hospitals, now New York hospitals are reallocating their staff into areas of assistance. We're not asking orthopedic surgeons to take care of patients with pneumonia, but we may be asking physicians to participate in call lines, answering questions that we can all answer, maybe looking at screening protocols and things like that. Today, we've granted emergency privileges, as an example, across the system to our advanced practice practitioners so that they can do medical screening exams in the event that we have to set up screening centers just outside of the emergency room. As part of the EMTALA requirements, they'll now be able to do that. They couldn't before. That's in excess of 500 personnel that will now be able to assist so that the emergency room physicians can actually take care of those patients that may be more critically ill coming in, that may have more advanced respiratory problems or other medical problems that we need to take care of. These are all the things that we're adapting to as time goes on. More to come. We are prepared. As a system, we are prepared to do whatever it takes in order to make sure that we can provide the services that our patients need. Along telehealth, we've expanded the privileging along telehealth, and Dr. Zellis leading the way around training and bringing up the telehealth access across the system is forthcoming right now. And so we are in good shape, but we have more work to do, and we'll keep you posted because it is fluid.
Yeah, and I think that's a really important thing for our viewers and listeners to understand right now. Ohio is a bit different than the coasts. We've had just terrific leadership from Governor DeWine declaring a state of emergency after the first 3 cases in the state that were reported at university hospitals. We've been ahead of the curve in social isolation, in closing the schools. And it's important to emphasize that, for instance, today, we do not have a COVID positive patient in our 1,000-bed University Hospitals Cleveland Medical Center. We have some PUIs, but no patients. Our rate of positivity of testing in our drive-through lanes has been about 3%. So I think we're monitoring the situation closely. We're prepared if it were to get worse. But right now, Ohio is very different than New York and California and Washington State. And we hope that the early intervention of our governor and of the hospital in changing the way that we're doing things will keep the situation in a manageable form.
And I just want to add, we're in contact with the mayor regularly. Mayor Jackson has been phenomenal. His questions when we meet are, "What do you need from me, and I will make it happen." And that's his statement every time we meet with him. And he's working closely with the governor's office as well. But all activities here are local, and the mayor has done a remarkable job, as have other mayors in the surrounding communities. But Mayor Jackson has done great. So we have all the resources from government right now that we need, and we hope that we continue to get resources from the federal government and additional PPE as manufacturing is stood up in the United States that will produce masks and other PPE in a more rapid fashion.
So we're hearing this question from a number of physicians. How will this affect our RVUs and our compensation plan?
Well, that's a great question. I think what I would have to say is it's too early for me to comment on that. The guidance from the governor, again, is about 2 hours old. We are trying to first respond to the governor's guidance and implement that by Thursday morning. There is no question that the leadership of University Hospitals Physician Services, Cliff McGarrian, Danny Ciccarella, and others are evaluating that impact now. What's most important now is that we focus on our patients and the care of our patients and doing the right thing. And that'll be something that we'll address in the coming days and weeks, but it's really too early to give anything definitive on that.
Can we talk a little bit about transfusional medicine and an anticipated blood supply issue?
Well, that's a very timely question. In fact, 5 minutes before walking in to this, Dr. Ted Technos contacted me regarding concerns related to bone marrow transplantation and the treatment of patients with heme malignancy, telling me that, Dan, there is a blood product shortage, and we're going to have to address it. I think there's several ways to address it. One is Dr. Hill and the transfusion team is redoubling efforts to make sure that transfusions are appropriate. Second, we understand that reduction in non-essential surgery or elective surgery will probably result in reduced use of blood products. And third, we are going to have to come together and call out to the public for focused blood drives. This is the time when people who are at home want to help. And we're going to have to call on them. We're going to have blood drives. It can be done safely. We can have appointments. We can test to do it safely. But just like a time of war, people are going to have to step up and donate blood for our patients.
So as we talk more about telemedicine, curious from a risk management perspective, what are your thoughts that traditional standard care will not be met? For example, no hands-on exams to observe critical findings, wheezes, so forth. Your thoughts would be appreciated.
Willie, I think you know a lot about the exemptions that are being offered now for telehealth.
So again, as has been said by all of us up here, the most important thing is the patient-physician relationship. And in the end, the physician and the patient need to decide when they need an in-person visit. I think telehealth can answer and deal with many issues for patients. They can do a lot of evaluations of the patient's symptoms. And oftentimes for people who aren't that ill or may not have that bad chronic disease that could precipitate the need to be come back into the hospital if they're not treated, you can take care of them through telehealth. If when the physician and the patient have that telehealth conversation and the physician has concerns, the expectation then would be that they would ask the patient to come in so that they could lay hands on them and be evaluated. There's some other opportunities around home health evaluations too, if the physician believes that that's important, and we may be able to create scenarios where home health could go out and help do certain evaluations by a healthcare provider doing those types of assessments. But in the end, it's the physician who's going to have to decide, does my patient need to come in to be seen by me with physically present so I can lay hands on them, or am I comfortable managing the patient over a telehealth visit?
We're about halfway through this webcast now, and there are some who may just be joining us. I think it's a good idea for us to revisit what is considered non-essential and take a good look at what that criteria is for having any procedures in the foreseeable future.
Joe, you want to touch on that?
Yeah, I suppose the way I think the easiest way to think about it really revolves around time sensitivity. You know, if we don't operate on somebody emergently, they could lose their life, or they could lose their limb, or they could lose function of an organ, those are obviously essential, non-elective operations. And then if we think about cancer care, obviously if we wait too long and somebody has a low-stage cancer and we don't operate for a while, it can metastasize and it can be upgraded. We don't want that to happen, and neither does the governor. So those are also appropriate. And then we think about symptoms, and that symptoms could progress if they're not operated on in a time consistent manner. Those are also essential. I think that another way of thinking about this is, well, how do we define non-essential? And then I think about things that don't matter for time. I think certain cosmetic procedures probably would qualify for that. Or let's just say an ostomy reversal, where the patient will still be okay and could wait long enough for this pandemic to go away before they have operation. So the way I think about it in my head is, how time sensitive is this? And if I don't operate on this patient, are they going to suffer if it's not in a reasonable amount of time? And if the answer to that is yes, I believe we should operate on them, and I believe the guidelines that we've been given allow us to do that. But if I can say, well, this patient is not going to be harmed by waiting, then we should wait.
Okay. And we should probably, without going into too much detail at this point, let people know that there are some very specific guidelines on how people will be contacted in the next 24 hours and beyond. And we will be releasing that information right after this webcast. So people can have it in print, correct?
Yes, and I think, as we said at the beginning, we will be posting the PowerPoint that was referred to during the webcast to the website and the digital workplace. This live webcast will also be recorded, so if you need to review, you can watch the recorded version. If you have friends who missed it, refer them to the recorded webcast as well.
All right, so back to some other questions. Would one of you like to address social distancing? It's a little bit off topic for what we're discussing at the moment, but certainly something that is incredibly important. And this physician says that they feel it needs to be addressed ASAP.
So again, around social distancing, this is common sense in part two. The first thing is, we know there are a variety of things that we need to do in general. We should be washing our hands with soap and water after we see or touch patients. Purell is good, or the various gel solutions are good, but soap and water is better for 20 seconds. It kills the virus. Second, in terms of social distancing just amongst ourselves, we shouldn't be shaking hands with people. As the mayor the other day did, he says, show me how you do the elbow pump. So we did the elbow bump, and that's about as close as you want to get to people. You'd like to have 6 feet as the recommendation around that, but obviously that's not always possible. But clearly, you don't want to be in large crowds of people. Now the president has made clear that 10 or less is preferred, having that social distance of a couple feet in between. And then the other common sense things of if people have runny noses or colds or things like that, you want to keep a little bit further distance from them. That's basically what it is. But as healthcare providers, at the end of the day, we do need to lay our hands on patients. We need to touch patients. We need to care for those patients. They're depending on us. And the expectation is our providers in this system will continue to provide the healthcare needs to our patients.
All right. As you look into the future, someone's asking you to do that. How many cases to be expected in the next 7 days? And we're hearing that we're 10 days behind Italy. Could you try to put some perspective into that for us?
Well, the caseload in Ohio went from the first 3 here only 2 weeks ago to 50 last evening. And so it's a little hard to predict. There were a little over 4,500 cases in the U.S. this morning, and it's doubling approximately every 5 to 6 days. So it's very hard to predict what's going to happen in Ohio. I think one of the things that I've been pleasantly surprised by is the very low number of inpatients in the health system. So while we have had a number of patients under investigation, while we've had patients who've been positive, most of them have gone home. We've had one or two patients at most who've even been on a ventilator for a short period of time. So I think we have to monitor this region specifically. It's certainly available for those of you who want to watch live on the Johns Hopkins CSSE website that updates on the minute, and we're continuing to do that. I think we hope that the intervention of the governor, the interventions that the hospital have done, will make Ohio different than what's happening in Washington and California and New York.
And I would just add, one of the other components of the numbers is that we've just started testing in Ohio recently on a wider scale than previously, because the test kits just weren't available, and they were very difficult to do, and there were very strict criteria because of the limited number of test kits that all had to go to the CDC for testing. Now we have the ability to test here at university hospitals. We have the ability to, our neighbors at CCF have the ability to test, and there are several labs that also have the ability to test here locally in the region. So as the testing goes up, one can imagine that the number of cases are going to go up. But as been pointed out before, 80 to 85% of people who actually end up having the COVID virus have very mild cases, and many of them never get tested. And so it's the expectation is the numbers are going to go up. The hope is that we continue to flatten that curve out and the number of sick patients don't go up too quickly.
Right. Who do we contact regarding telehealth training and getting our providers up and running for that?
So I would suggest that you reach out to the digital workplace. There's information on there about telehealth. We'll make sure that Dr. Cindy Zellis updates that. We'll put an FAQ component to that after this WebEx, and she can certainly answer that throughout for the entire system of what the processes would be to expand and use telehealth.
Danny Ciccarella, who's our Chief Operating Officer of University Hospitals Physician Services, has made it a priority to get everybody credentialed for telehealth in the Primary Care Institute and in the Pediatric Primary Care Institute to rapidly bring up nearly 500 providers onto tele by the end of the week. So I think we're making a lot of progress in that, and that's great for the safety of our patients.
We've also done that now in behavioral health. We're in the process of doing that now. We've got various waivers, and we've had the legal requirements reviewed during this emergency to manage that as well.
Could you please address crowded waiting rooms? How is it responsible to permit large crowds of people waiting in a small space to discuss elective surgery?
You want to take that, Joe? Waiting rooms for surgery?
Obviously it's not ideal. I mean, being all honesty, I think that as we've heard about, we need to have some distance amongst us. I know we're limiting the number of visitors that can come in, which will not tax our environments as much as they are in the past. And so that hopefully by, let's be honest, decreasing the number of operations, decreasing the number of family members that come, and the fact that we all should be knowledgeable about the fact that we need to keep our distance from each other, that hopefully that will not happen moving forward.
Willie, do you want to update on the visiting policy and how you're constantly monitoring that to potentially change it?
Sure. So we're looking regularly at the visitor policy, and a lot of that depends in large part on the rate of spread of this and how many patients are coming in the hospital. We recently changed the visiting policy so that we're respectful of issues around Rainbow and Mac House, around children and people having babies. They have 2 visitors allowed in those areas for obvious reasons. Seidman Cancer Center through Dr. Technos and Brett Glosbecker, the CMO, came up with a visitor policy that matches for the new policy for all of our hospitals, with the exception of 2 floors, Seidman 3 and 6, I believe, where they have limited to no visitors because of the high-risk patients on those floors. In general, across the system, we came up with a system policy, and we really are trying to systematize the approach to things so that we don't have people doing different things and getting confused. But as of today, it is 1 visitor per patient per day. All visitors have to check in at the front desk in every one of our facilities. That's also true for ambulatory surgery centers as well. And those people are assessed when they come in for any respiratory symptoms, including the cold. If they have that, they're asked to leave. And we also are checking people coming through for fevers. And if they have fevers, they're asked to consult their physician as visitors. And that's the policy. There are places, I can tell you, in the West Coast, again, further along, where they've gone to no visitors, but we are not there yet. That is always an option in the event we need to do that.
Will all surgeries that are deemed necessary need pre-admission testing if we are trying to limit unnecessary contact?
No, I think the answer to that is no. I mean, we have many ways of assessing our patients preoperatively, what we have done in the system is this: Dr. Popovic has one of the nurses call the patient ahead of time, and often the assessment can be done over the phone. But if it's deemed important that that patient comes in for certain reasons, then that patient will need to be seen in person. But we try to do, even today, as much as we can over the phone to determine whether it's necessary for them to be seen in person.
All right. Can we go back and just revisit the departments that you anticipate will be hit the hardest with this information, and reassigning, looking for other ways for them to serve here at UH?
Yeah, I mean, I think if we think about where we do a good amount of elective surgery, I think it has to come into areas of, sports medicine or joint replacement, or we think about general surgery, we think about hernia repairs. Obviously, there's plastic surgery, cosmetic and reconstructive things that patients can have done later. But there are areas in those fields that are emergent and urgent surgery, so I think that there will be, opportunity there as well. One of the things we haven't touched upon, and hopefully it will never happen, but some of our healthcare workers may need to stay home to take care of family members. And so I would think that we're going to need people to work in different areas, and it's going to be a very fluid situation as we see the needs of our healthcare workers and the needs of our patients and what types of things we need to do. I personally believe we're all going to be very busy. It's going to be all hands on deck.
Is it a department by department decision on how to handle employees in that department, non-clinical employees who might be left with shorter hours? How do physicians and department leaders need to handle that?
I think it's a little premature to come out with a blanket policy. I know that Tom Snowberger, our Chief Human Resource Officer, is evaluating that right now. There's no question that we are facing a labor shortage environment in which the schools are likely to be closed through the rest of the year. We have employees, nurses, techs, who have children at home and are not going to be able to work continuously over that period through the end of May. So we're going to need nurses. Jason Pertz, and our nursing council is working right now on trying to figure out how can we repurpose nurses from different areas to help out in these areas of shortage, increase the PRN pool, enhance the enterprise nurse network. We need nurses. Just yesterday, I was fortunate enough, in a very inspiring way, to go to Landerbrook to see the drive-through testing. There were probably 100 individuals working this very complex and well-orchestrated machine of keeping people in their car with their seatbelt on and getting them sampled with nasal and oropharyngeal swabs for COVID. That's a lot of people. Very eager to work there, tremendous activity, and we're going to need that across the health system. We have 2 testing sites, and we have plans for more with broader geographic coverage of our 16 counties.
Is there any idea on changes to clinic, particularly post-operative visits, post-operative care?
I would say the answer to that has to be yes. I think there's a lot of opportunity to do telehealth and telephone calls in that situation. And I think it's going to have to be assessed. Again, the physician-patient relationship is paramount, and I think that each physician is going to have to think about the care and how is the best way to deliver it for that individual patient. I think there's lots of opportunity there.
You've already answered this question, but we're getting it a lot. So let's revisit. How do we know what date we may resume normal scheduling? This physician says personally booked for at least a month with elective surgery. How many weeks should I expect to delay?
I don't think we can answer that question in all honesty, because we don't know what it's going to be like next week or the week after. Maybe if we're very fortunate, this will all be over in a few weeks and we can get back to doing what we all enjoy doing. Or it might be 3 months, and we don't want to put our patients in situations where they're being scheduled and rescheduled and scheduled and rescheduled. So we're asking people to be patient and understand, and that the schedule will be postponed, but we're going to keep track of it, and when we can take care of them safely, we will.
Are there any plans to utilize OR staff and infrastructure for ICU surge?
As you may know, there are places in Europe that are using operating rooms as intensive care units today, just because that's where the ventilators are. Hopefully we won't come to that, but that is always a possibility. We'll do what we need to do to take care of people.
Speaking of, hopefully we won't come to that, this question. What will the protocol be when we run out of PPE?
So again, the hope is that that doesn't happen, and the hope is by being judicious in our practices today, by making these very changes to our operating schedules and all, and reducing the non-essential employees who are coming in contact with patients, we'll be able to preserve our PPE. If that happens, we will have to deal with that at that point. There's not an answer to that right now, but I can tell you in the United States is an extremely resourceful country. From the president to the governor on down are waiving a variety of regulatory impediments to companies coming out and being innovative and manufacturing these types of devices. And I do believe that in the United States we will be able to manage this with the incredible talent we have in the country. Obviously, no one knows when and if that happens, but I do believe we will be able to do that because there's a tremendous amount of work going on right now to be able to manufacture these things here in the United States.
You know, I think also we're leveraging local talent. Steris Corporation has come up working closely with 3M with a very likely possibility of re-sterilizing PPE that we have. In addition, I think we have to give a shout out to Steve Stanley, to Sean Osborne, and to Chad Fleischer from our supply chain. I mean, these guys are working and their teams 24/7 getting us the things that we need. And I want to give that shout out. And if you see them in the hallway, they are finding everything from hand sanitizer to cleaning solutions to masks. And it's just been amazing to watch when he sees me in the hallway and says, "Dan, I found 4,000 swabs." It turns out these testing swabs all come from Italy. There's apparently one company that subcontracts to all the big providers in the U.S. But Sean has found nasal swabs. So thank you to them, and it's that kind of teamwork that we need right now.
Somebody is kind of thinking outside the box, wanting to help save PPE. What is your position on using cloth scrub caps to decrease use of the reusable ones?
Yeah, I mean, the guidelines are that if you use a scrub hat, you just got to wash it every night. It's a great idea.
Okay. Are there limitations to elective admissions, for example, acute inpatient rehab?
So again, part of this is the physician decision with the patient of whether or not this is a critical component of the patient's ability to improve their function and restore their function. Obviously, if they don't need something like that, the preference would be to go home, to do exercises at home, possibly to have some home care or home therapy. On the other hand, for some of our patients, as examples, many patients that have had strokes, they are going to need inpatient rehab for their care and for their improvement, and that will continue to be available to them because it's the right thing to do for patients.
All right. This is certain to make an impact on RVUs. Is that something that's being suspended as well? And we've kind of gone there, but we're getting a lot of questions about it.
I just want to emphasize we're now about 2.5 hours out from the governor's guidance. UHPS will be looking at this very, very carefully. Our focus right now is on taking care of patients. The business side of what happens to procedures is being modeled and forecasted, and it's just too premature to say that. We have to keep our focus right now on taking care of patients, preserving the doctor-patient relationship, and then the second thing is the safety of our employees. And those are the two things as a person leading the coronavirus preparedness team. I know Eric Beck as the leader of our Unified Incident Command, Willie, Joe, and others. That's what we're focusing on right now, and we'll get to that when we can.
Is there a downside to canceling the next 2 weeks and then playing it by ear week by week? I'll just say this, we're getting a lot of questions about how do you recommend we schedule out? It's not about the canceling right now, but scheduling out is a big concern.
So I would just say, Joe, from the governor's guidance and what he's done with cancellation of schools, this has really got to be thought of on the time frame of a 30 to 90 day. This is not 2 weeks.
Correct.
And I think because we've had a lot of discussion about that, we don't want to schedule people and cancel again, schedule and cancel. So what we're doing right now is advising postponing. We're collecting the names of everybody, and we're going to encourage them to call back in a queued-based fashion once we get the go-ahead from a different guidance from the governor. But I think it's really premature. It could be 30 days, it could be 90 days, but in the absence of any hard number, what we're doing is postponing, and we will call to schedule when we can.
Yeah.
What do you think about that, Joe?
I completely agree, Dan. I think that's a great recommendation. But I would like to emphasize is we do have the opportunity to take care of the patients who need essential surgery today. And we should continue to actively take care of the patients who need us, whether it's our cancer patients, our heart patients, our neurosurgical patients. We're going to be able to take care of them for the foreseeable future, so we should continue to do that and schedule them. But, and I think that the patients who have things that are not time-sensitive or life-threatening would understand. I think all of us would understand that.
So we've got about 5 minutes. So I'd like to leave these last minutes with you an opportunity to recap what it is that you want to send home to everybody, and then a reminder of how people can find this information and continue sending in their questions, because we will be providing a frequently asked questions section for people to go to.
Great. Well, I'm going to turn to Willie to give the top line on the criteria that the governor provided related to essential and non-essential surgery. And I think that's what we want people to understand from his guidance today.
So again, the governor was very clear that the criteria that he set forth, and again, I want to be clear, the governor did this to preserve PPE, to preserve the access of patients who really need to be in the hospital, and to preserve the availability of things like ventilators for patients that need to be seen. But as he laid out, it is he does not want to impact any patient where there's surgery that is going to preserve life, preserve limb and function, preserve potential upstaging for cancers or spread of cancers that are curable. He wants them taken care of, and he wants to make sure that the risk of anything that is rapidly increasing in symptoms that could have that functional, permanent functional disability goes forward. That's the key. What I would also say is this is very fluid, and I think that we'll be able to see in the next 30 days the trends from California and Washington and New York, because they have been hit earlier than we in Ohio and other parts of the country have been hit, to see where that curve is in the United States, and that'll give us some additional information. But at the end of the day, I just want to say I want to thank everybody who's been so helpful and patient with working with us around this. Things continue to change almost daily. We'll continue to keep you updated on all those changes. We're putting our patients and our employees who are caring for those patients first. And I also want to thank the staffs of every hospital. We have thousands of really sick patients in our hospitals today, every day, that do not have COVID-19 and are not persons under investigation. And our teams, our nurses, and our physicians are taking care of those people in an incredible way and staying focused on that care, even when this is a major concern and a distraction in part to that care. They're doing a phenomenal job, and I want to thank all of them for what they're doing every day. It's really amazing work, and really is a community, the UH community and the UH family coming together to do the right things for the patients in Northeast Ohio and beyond.
So, Joe, close of business Wednesday is the last day for business as usual. Thursday morning, essential surgery only. Just tell us very briefly the process. Who's going to cancel the surgeries for Thursday and Friday, and what do we do next week?
Yeah. So again, we ask all of you to take a good look at your schedules and look at Thursday and Friday. And if you can, by 8 a.m. tomorrow morning, let the operating rooms know that these cases are non-essential cases. So that either A, if you're at CMC or a hospital that has nurses that can call the patient or routinely calls the patient preoperatively, that calls can be made. But it's very important, obviously, for you to maintain your relationship with that patient and have your office follow up with them and talk to them about why it's being postponed, and that you'll be able to get to them in the future when you can. The important parts, as Willie has talked about, is governance. So there's going to be a little bit of procedural change in the morning, and that the surgeons will need to attest to the operation, and that hopefully moving forward when we schedule cases next week and beyond, that the attestation accompanies the schedule. You know, our goal is to help you take care of your patients in the operating room as best we can. We know this is going to be a little disruptive at first. Please be patient, but we'll all get through it together, and I think we'll be better in the end.
Great. So I think just to conclude, the most important takeaway today is that this is patient-centered. We're preserving the doctor-patient relationship. This is being evaluated on a case-by-case basis. Do the best you can as a provider. If you have any questions, you have your department chair, your service line leader, your surgery chief in community hospitals, and the CMO to go up. If that can't be resolved, if you have a concern that this is essential surgery, we can contact Joe and Willie in that. So very important. Patients, number one. The safety of our employees is number two. In terms of where you will find information, the PowerPoint from today's WebEx will be available on the digital workplace. The WebEx today, for those of you who couldn't see all of it or have friends who want to see it, will be recorded and can be seen also and will be available on digital workplace. We want to thank you for joining us today. We will be back to talk to you if there are any new developments. And so stay tuned for those, and thank you for all you do every day. Thank you.